Well, thank you for the introduction, Dr. Lang, and it's my pleasure and honor to present during Grand Rounds today. What are the objectives of my talk? Well, at first, I'd like to talk a few words on sepsis and urosepsis. Then I'd like to give an overview over the literature regarding urosepsis after ureteroscopy and potential risk factors, and then review the literature pertaining to intrarenal pressure and associated complications. And last but not least, I'm very happy to have participated in a study that was led by Dr. Chu last year, where a concept device by Boston Scientific was tested, a novel flexible ureteroscope with a built-in pressure sensor. So we'll talk about this at the end of the talk. And we'd like to start things off with a clinical case that Dr. Chu brought, and he will present it. Thank you for that.
Yeah, so this is a 65-year-old gentleman, very classic. He is from Whitehorse and was transferred emergently to Vancouver, I think with a lot of pain, no fever, right-sided flank pain. You can see that sort of 8 to 9 millimeter stone at his right UPJ. He's got metabolic syndrome. He's not overweight or anything, hypertension, coronary disease, appendectomy. So we see the right ureteric stone. And like, a lot of patients from Whitehorse, I think they often get better care than some of our Vancouver patients. You can go to the next slide, Roman. We decided on a more invasive definitive therapy with ureteroscopy rather than shockwave, where you send in some shocks and hope that they pass it all and then go home. But I mean, that's fine if you live in Vancouver and you can just travel 30 blocks to come see us. But when it's a flight, we tend to do something a bit more invasive, and it's got a bit of a partial duplex system. You see that there. So we used a ureteral access sheath. We used a digital flexible ureteroscope. We lasered the stone with the HOMI-MAG laser. It was dusted. Everything seemed to go fine during that case. We stented him, and then we were about to send him back. And we actually did send him back, but there were some problems with the intrarenal pressure, as you can imagine. This is why I'm bringing this case up, that and the importance of why it is important. So essentially, had a complication from all this, and you can Roman, you can talk about the pressure now, and then we'll talk about how this case ended up later.
Yeah, thank you, Dr. Chu. So when we talk about sepsis and urosepsis specifically, we all know that sepsis is not a specific disease, but rather a syndrome encompassing a still mostly unknown pathobiology. It's a very complex syndrome, and at present it can be defined as a constellation of clinical signs and symptoms in a patient with a suspected infection. And when we talk about the definitions, the first definition, there was a consensus conference on it 30 years ago. And the original concept of sepsis basically relied on the systemic inflammatory response syndrome, and that defined sepsis. And we also had the subset of severe sepsis and septic shock. However, this definition was redefined in 2001, but they could not find consensus on a new definition and made minor changes to the previously established one. And in 2016, they met again, and the most contemporary, most modern definition was developed. And now they use the sequential organ failure assessment score, or sepsis-related organ failure score. So when we talk about the SIRS criteria, they're generally known, but this is just a quick reminder. Temperature over 38 degrees Celsius or below 36 degrees, heart rate of over 90 beats per minute, respiratory rate of more than 20 per minute, or a partial pressure of carbon dioxide of less than 32 millimeters of mercury, and either leukocytosis or leukopenia. So the original concept of sepsis included a proven or suspected infection, and sepsis was defined as this proven or suspected infection plus at least two of these SIRS criteria. Sepsis could then lead to severe sepsis when organ dysfunction or organ failure was evident, and the most severe form, the septic shock, with patients requiring vasopressors and having elevated lactate levels. So that was the original version of 1992. And this is the 2016 definition, the most modern one, where it's defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So this is now in the focus, attributing to the underlying pathobiology. And to assess it, the sequential organ failure assessment score is used. And when a patient has more, 2 points or more, he's regarded as septic. We also know that a score of 2 or more, when a patient has a score of 2 points, the in-hospital mortality is about 10%. And they abandoned the concept of severe sepsis. So now we distinguish only between sepsis and septic shock, where septic shock is a subset of sepsis with particularly profound circulatory, cellular, and metabolic abnormalities. And again, patients need vasopressors and have elevated lactate levels of greater than 2 micromolar. So to explain the SOFA score real quick, basically it focuses on the organ systems with respiration, the partial pressure of oxygen divided to the fraction of oxygen delivered. So in a healthy person, it will be 100 divided by 0.2, as we have 20% oxygen in the air, which equals to 500. So the less you have, the more points you get, and the same applies for the other organ system. Platelet count for coagulation, bilirubin for liver function, hypotension with regards to cardiovascular system. So it's the mean arterial pressure of less than 70, and you get more points for with increasing levels of vasopressors. And the central nervous system assessed via the Glasgow-Coma scale, and renal function with creatinine. So now you see this table with all these values. Obviously, clinicians developed a quicker scoring system. So the quick SOFA score was developed that only focuses on respiratory rate of greater than 22, altered mentation, and the systolic pressure of less than 100 millimeters of mercury. This score is mainly used for patients outside of intensive care units or for quick assessment, while the SOFA score is mostly for patients in intensive care units. So now that we know how sepsis is defined, what is urosepsis? It's a life-threatening organ dysfunction caused by a dysregulated host response, again, to infection originating from the urinary tract or male genital organs. So why is this important? Well, it accounts for 20 to 30% of all sepsis cases, and we know that about 20% of patients that survive their septic episode will have long-term sequelae in terms of impaired cognitive function and physical disabilities. The data that's out there specifically focusing on urosepsis is scarce, and we know that about more than 60% of all urosepsis cases are due to urinary tract obstruction, be it either urolithiasis or malignant obstruction, and about 50% of all urosepsis cases are caused by E. coli. So topic of my talk is urosepsis after ureteroscopy. Why is urosepsis after ureteroscopy important? Well, as we all know, the prevalence of stone disease is increasing worldwide. This is data from the United States comparing the 1980s, where prevalence was 3.2% to 2014, where it increased to 10.1%. So there are multiple factors. One is that more and more patients are having stones. And the other factor is that if you take a look at the guidelines, these are the European guidelines, when is ureteroscopy considered a first-line treatment for urolithiasis? And you can see that ureteroscopy can be applied in almost any patient, maybe with the exemption of large kidney stones. However, people started to tackle even these larger stones via flexible ureteroscopy due to advancements in scope technique and also in laser technique. So since the indication for ureteroscopy is very wide, ureteroscopy is on the rise. And this is data published in 2017. The red line indicating the trend in Canada. So we have data from roughly 1990 to 2010, and we see a steep increase in the patients that are treated with ureteroscopy. And I bet if we extend the x-axis to 2022, we'll probably be about here. So we also published some data on the situation in Germany last year. So that's shockwave cases. Obviously, that's the map from Germany. And you can see the big blue dots indicating clinics that did more than 500 shockwaves per year. That's the situation in 2006. And on the right side, you see the situation in 2019. So in the very country the shockwave lithotripsy originated, it's been widely abandoned, and the shockwave numbers declined by 74%. And on the contrary, ureteroscopy cases increased by 143%. So we have more patients, and we are doing more ureteroscopy in these patients. So next, I'd like to present the systematic relevant meta-analysis by Dr. Bojani from the University of Montreal and Dr. Chu. So they ask basically two questions. What is the incidence of urosepsis after ureteroscopy? And are there potential risk factors that can be identified to better predict the risk for urosepsis after this procedure? And they screened 251 articles, and 13 met the eligibility criteria and were further analyzed. Here you can see the studies, 13 in total. All of these studies were done between 2016 and 2020. 8 were retrospective in design, 5 were prospective studies. Case numbers varied between less than 50 and more than or almost 1,500. Median age was 51 years, and predominantly male patients with 64% over the total patient cohort. And all these factors on the right side were investigated for predicting postoperative urosepsis. So it's BMI, ischemic heart disease, diabetes mellitus, recent urinary tract infection, a stone history, whether patients had a positive urine culture prior to the procedure, whether patients were pre-stented, and hydronephrosis, pyuria, and the cumulative stone size were investigated. Obviously, you can see not all of these studies reported on all factors. So we just reviewed the definition of urosepsis, and you can see here, these are the definitions that were applied in these studies, and it's very heterogeneous. So they did not consistently report on the definitions they used. Some did not specify how urosepsis was defined for their study, and most used either SIRS criteria or a mixture of the SIRS criteria or the 1992 definition. So we have to keep this in mind. What about the incidence? So in the pooled analysis, they found a 5% incidence, and the incidence between the studies varied significantly between 0.2% and almost 20% in some studies. However, pooled incidence was 5%, so 5 in 100 patients develop a septic episode after the procedure. In terms of risk factors, these 6 risk factors were significant in the analysis. So whether a patient had a preoperative stent placed, a positive preoperative urine culture, ischemic heart disease. age, longer procedure time, and diabetes. And with the reds are the possibly modifiable risk factors that we'll now focus on. So how do we prevent sepsis from ureteroscopy? Well, if we evaluate risk factors for sepsis that are established, we have pre-stented patients, higher comorbidity. Other studies also found BMI and female gender. We know that the elderly patients are more at risk, and patients that have had a prior septic episode. So if we focus on the pre-stented patients, this is data from Israel, where they investigated the time to treatment after stent placement. So it's basically the indwell time of the double J stent. And they found that after 2 weeks, they saw an increase, and a significant increase after 4 weeks. So they basically said that within the first 4 weeks, this is the safest time period to perform ureteroscopy. And we know due to the pandemic, these times were significantly longer in most countries in the world. So these patients are probably at a higher risk to develop infectious complications. With regards to ureteral dilations, when you put a stent in a narrow ureter, we know from studies that this ureteral dilation takes place within the first week. So in terms of ureteral dilation, we are probably fine doing the ureteroscopy after 2 to 4 weeks. This is data that has just been published, basically the same research question they asked, and they found a significant difference with the 2-month cutoff, where they found significantly more patients developing infectious complications when the indwell time was more than 2 months. So what about antibiotics to prevent infectious complications? Well, to take a look at the guidelines, the AUA guidelines state that antibiotic prophylaxis should be administered prior to stone intervention, and obviously based on cultures and local antibiogram. And the European guidelines also state you should obtain a urine culture. Any pre-existing urinary tract infection should be treated, and patients should be offered perioperative antibiotic prophylaxis before any urological procedures. However, we also do know from this big study, ureteroscopy study by the Endourological Society, that's a worldwide study that where more than 1,000 patients were investigated, and they did not find a difference in patients with a negative urine culture that underwent ureteroscopy when compared to patients that have had a prophylactic dose perioperatively. They did not find a difference with regards to infectious complications. However, they established female gender and a higher ASA score, higher comorbidity as potential risk factors for infectious complications. That's another study by Dr. Chu and Dr. Lang. 81 patients retrospectively reviewed. They either gave a single shot perioperative antibiotic prophylaxis versus patients were sent home with antibiotics, and they found a higher rate of infectious complications in the patients that received postoperative antibiotics versus the single dose. However, this difference was not statistically significant. What else can we do to prevent sepsis in patients undergoing ureteroscopy? This is a study done by Olivier Traxier, published in 2015, and they assigned patients to 2 groups. In the one group, ureteral access sheath was placed, and in the other group, ureteroscopy was performed without the sheath, and they found a more than 3-fold higher sepsis rate in the group that was treated without a ureteral access sheath as compared to the ones with an access sheath. However, in the literature, you can find studies on both sides. That's another study. It's a smaller study, 43 patients with mostly larger stones. However, they did not find a difference in stone-free rate and infection rate with regards to ureteral access sheath use. And the sepsis rate was pretty high at 11.6%, but this can be mostly attributed to the larger stones and patients undergoing multiple procedures. So now that we know about this, is there evidence that higher intrarenal pressures might be associated with postoperative infectious complications? That's a study that investigated 305 patients with a unilateral blocking ureterostome. They basically assigned their patients into 3 groups with low, medium, and high irrigation pressure at 60, 80, and 100 millimeters of mercury. It was about 100 patients in each group. The OR time was comparable between all these groups, and they found a significantly higher sepsis rate in the medium pressure group and in the high pressure group. Was more than 3-fold higher. So that indicates that maybe this increased irrigation pressure could lead to infectious complications. So now I'd like to talk about the importance of intrarenal pressure and what is known on the subject, and then we'll talk about the study with the concept device. So intrarenal pressure, from the literature, we know that the baseline intrarenal pressure is about 0 to 6 centimeter of water. And just to explain, 1 millimeter of mercury equals 1.4 centimeter of water, since these two measurements are used in the studies. This baseline pressure can go up when there's an obstruction of the urinal unit to above 20 centimeters of water. And we know that during diuresis, this pressure goes up to above 27 centimeters of water. However, only for a very short period of time. So what are possible complications that are associated with elevated intrarenal pressure? Well, we have pilorenal backflow, fornicele rupture, pain, infectious complications, and renal damage. So let's talk about pilorenal backflow. From the literature, we know that a minimal amount of pilorenal backflow can occur with pressures as low as 14 centimeters of water. However, significant pilorenal backflow was observed when the pressure was increased to above 40 centimeters of water. And that's a study done by the group of Dr. Munger, where they did ureteroscopy in a porcine model. They mixed saline with black India ink and then performed ureteroscopy for 30 minutes. And they used different irrigation pressures at 50, 100, and 200 millimeters of mercury. And what they showed was that with the increasing irrigation pressure, the amount of ink inside the renal parenchyma increased. And the other finding was that the use of an access sheath significantly lowered the pressure. So what about fornicele rupture? Studies on fornicele rupture are very old. They date back to the 1980s and were done in a rabbit model. So what they found is that the pressures of above 80 centimeters of water can lead to fornicele rupture. What about pain? There's been a lot of interest in the association between pain and intrarenal pressure. So this is one study published in 2012, where they investigated 15 patients that underwent PCNL. All patients had a prior negative urine culture and had non-infection stones. A nephrostomy tube was placed and a 7 French selective catheter inside the renal pelvis. This catheter was then connected to a transducer to measure the pressure, and contrast was injected at a rate of 1 cc per second via the nephrostomy tube. And the pain threshold, so patients were asked to give the pain on a visual analog scale, and 5 was considered as significant pain, and pelvis pressure was approximately 34 millimeters of mercury. So that was the threshold for pain, and it ranged from 20 to 53 millimeters of mercury. So what about infectious complications? So that's where most of our evidence is. And this is a study, 260 patients undergoing flexible ureteroscopy. And the primary endpoint was the occurrence of SIRS postoperatively, which occurred in 8.1%. And they tried to identify associated factors, and they found that the gender, stone size, and interestingly, the irrigation flow and the irrigation volume played a role. So that's their analysis. 21 patients out of these 260 developed SIRS, and irrigation flow and irrigation volume was significantly increased in this group. That's another study where they enrolled 234 patients undergoing flexible ureteroscopy. They used the 12-14 French sheath in all patients, and then assigned the patients into 2 groups. So they used irrigation at 100 to 150 millimeters of mercury in both groups. And in one group, they also used a hand or operated irrigation pump. And what they found is that they found a significant difference between patients, the patient group where the hand pump was used. So about 7% met the SIRS criteria versus 1.1% where only pressure bag irrigation was used. And also hypertension and tachycardia, well, they found a significant difference. Flank pain also higher in the group where the handheld pump was used. Another study, this time patients undergoing PCNL, randomized to either 80 millimeters of mercury irrigation pressure or 200 millimeters of mercury. And on their multivariate analysis, also with SIRS as the primary outcome, they found that irrigation pressure was a significant or an independent predictor of postoperative SIRS. What about renal damage? Also, only in study that dates back to the 90s, ureteroscopy in a pig. They placed a nephrostomy tube, connected it to a transducer to measure intrarenal pressure, and then found that pressures of above 200 centimeters of water, they found changes in the kidney upon histology, and the rupture of the kidney was found when extremely high pressures were exerted. So what are the factors that influence intrarenal pressure? Well, irrigation plays a great role. We have gravity, pressurized bag irrigation, and hand pump system. There's self-filling syringe systems, or you could use a conventional 20 or 50 cc syringe. We know that once we put instrumentation into the working channel, be it either a basket or a laser, part of the fluid is obstructed, and we have that this can lower the pressure. We know that if you use a ureteral access sheath, that this can lower the pressure, but there's not a lot of data with regards to size, and especially with regards to location of the sheath. And we know that pressure is higher inside the calyces when compared to the renal pelvis. So questions we need to address in the future are intrarenal pressure. What is the clinical impact, and what's the clinical impact of pilorenal backflow? Does it have long-term consequences? What are the thresholds that are safe? What about postoperative pain? Is it either a peak maximum pressure, or is it a sustained pressure over a longer period of time that causes postoperative pain? And for infectious complications, is there a cutoff that we can define? And are there, or is it more the patient factors that we need to consider and need to address preoperatively? So this is the concept device that we investigated last year. It's a Boston Scientific flexible single-use ureteroscope with a built-in pressure sensor. It looks much like the LithoView one that's on the market, and this new device has not been FDA approved. Yes. So first thing we did was measure pressure with the concept device and compare it to a specifically built-in pressure chamber to address the accuracy. And we found that the concept device measured the pressure very accurately. We also did comparisons with regards to resolution and color imaging. On the left side, you see the color checker, and here's how it's represented by the concept device. Here on the left side, you see this diagram. That's where the curve of the intrarenal pressure will be can be seen, and then there's the threshold at 50. But this threshold is arbitrary. We do not know. We do not have a threshold yet. So that's just to demonstrate the resolution of the scope, which was pretty good. And we also tested this, but we'll focus mainly on pressure now. So here you can see we go up into the kidney, ureteral axis sheath, UPJ. Now we're inside the kidney, and that's the stone we placed there. And you see pressures baseline of about 10 to 14 millimeters of mercury. With this, we used gravity irrigation here, and you see pretty good visibility and pretty good picture. So on this video, you see the various irrigation methods. First, we see gravity irrigation, and you can see gravity irrigation at 80. We had our pressure of about 10 to 14, and this goes up significantly when we use a pressurized bag at 300 millimeters of mercury. So we reach pressures of more than 110. With the self-filling syringe, you can see here on the from the right side coming in the laser fiber. So even with the laser fiber in, we saw pressure going up to above 140 with the self-filling syringe system, and with the manual 50 cc syringe, we experienced pressure, very, very high pressures. Although the laser fiber was in, pressure was rising up to about 200 millimeters of mercury. So one question we tried to address with this study is, where should we put our axis sheath? Where's the best location for it with regards to intrarenal pressure? These are the possibilities. You can either put it inside the renal pelvis. However, this can impede the deflection of your scope, especially when you work in the lower pole. You can put it below the UPJ or in the distal ureter. However, as we all know, sometimes you start a case and the axis sheath is inside the renal pelvis, and then during the case or at the end of the case, you find it that it is located into the distal ureter. So we then measured the pressure with various irrigation systems that you can find here on the x-axis. So you have baseline, gravity at 80 centimeters, pressure bag irrigation at 150 or 300 millimeters of mercury, self-filling syringe, and manual. And on the left side, this is with the sheath located at the UPJ. This is inside the renal pelvis, and this in the distal ureter. And here you have no laser and with laser. And we tested 3 sheath in total, an 11-13 French, 12-14 French, and 13-15 French. And what you can see, we observed the highest pressures when the access sheath was located at the UPJ, and this lowered in the distal ureter, and lowest pressures were found in the renal pelvis. Also, we observed lowest pressures with gravity irrigation, with P150, P300, and SAPS was more or less comparable, and highest pressures were observed with the manual 50 cc syringe. So what we saw is that the bigger the access sheath, the lower the pressure was. However, the trends that we observed with the 11-13 French were also seen with the 12-14 and the 13-15 sheath. However, as you can see here, with the bigger sheath in the renal pelvis, pressures are very, very low during the procedure. So we did the statistical analysis on our measurements, and what we found is, with regards to ureteral access sheath size, 12-14 and 13-15 provided the lowest intrarenal pressure. With regards to location, we found, and we did not anticipate that, but we found the highest pressures when the URS was positioned inside or just below the UPJ. Then it was lower in the distal ureter, and lowest pressures, in the renal pelvis. Then with regards to irrigation methods, gravity had the lowest pressures, manual syringe had the highest pressures, and P150, P300, and SAPS were comparable. With regards to location, higher pressures were found inside the calyces when compared to the renal pelvis, and putting in a laser fiber significantly lowered intrarenal pressure. So now that we know that the beneficial effects of access sheath in terms of lowering pressure, why don't we always use the biggest access sheath there is? Well, the ureter is still a fragile organ, and this is a publication from 2013 where Olivier Taxier and Alexander Thomas published results on ureteroscopy cases where they used an access sheath, and then they inspected the ureter after they removed the access sheath in all cases, and they came up with a grading system where this is a grade 1 mucosal lesion, this is a grade 2 lesion where you find involvement of the smooth muscle of the ureter, and the grade 3 is a full perforation, and grade 4 is a complete avulsion of the ureter. So in their study, 359 patients underwent flexible ureteroscopy with a 12-14 sheath. About half of the patients were pre-stented, and ureteral injuries occurred in 46.5% of all patients. However, most lesions were low grade, but 13.4% of patients had high grade lesions, 2 to 4 according to their grading system. And what we know, pre-stenting significantly decreased the risk of ureteral injuries in this patient cohort. So now that we know that these injuries occur not or quite frequently, this is a nice study that was done in 2 centers where they evaluated all their injuries and prospectively followed these patients with a median follow-up of 35.8 months. And they found only 3 patients had hydronephrosis, with only 1 patient having ureteral stricture in the long term. So long-term sequelae seem not to occur pretty often, and most of these injuries should heal nicely. To conclude, ureteral axis sheath 12-14 and 13-15 French provided the lowest intrarenal pressure. According to our study, it seems best to locate the axis sheath in the renal pelvis, and below the UPGN, the distal ureteral pressures were higher when compared to having it inside the renal pelvis. We don't know yet what the significance of these higher pressures is in terms of pain and infectious complications, but we will have a tool for the future, and I guess there will be a lot of studies comparing clinical outcomes to intrarenal pressures once the device is FDA approved. So now I'd like to go back to our case. So we have seen this in the beginning. Right-sided ureteral stone. Patient will underwent ureteroscopy. And Dr. Chu, do you want to continue from here?
Yeah, it's kind of airing out some laundry. If we go to the next slide. So the patient went back to Whitehorse, and then we got a call from them because he went back to he removed his stent and then went back to the emergency room because he had so much pain. So look at this right here. I've never really seen this before. And he now has this large amount of either hematoma or fluid. They thought it was sort of old hematoma outside of the kidney, squishing the kidney, almost like a subcapsular hematoma, essentially, and a bunch of fluid in there. And because they gave him contrast too, they also noticed a renal mass, which of course we don't notice when we do a non-contrast CT. If you just show that CT again, and then you'll see that there is a central right there, renal mass right there. So very difficult to partial. And, so we saw this and I said, oh God, and this guy was in so much pain. And this guy is, he's a sheet metal worker from Whitehorse who kept asking me, Doc, when can I get out of here? I need to get back to work. Like, this guy is not a complainer. So we flew him back. And of course we watched him. His hematoma became infected. He became febrile. The pain was getting worse, and he actually even required a blood transfusion. And then we ended up doing a nephrectomy urgently on post-op week 9. And actually, sorry, Roman, if you go back one more slide again and just show the CT, this mass and infection actually started to invade into the psoas fascia. And if you stop it down below there, you'll actually see it. So there it is right there. Keep going. And then as we go down here, you're going to see it basically, you're going to see it looks like it starts being contiguous with the psoas fascia. And, we always think, oh, it always looks like that. But when we went in, we actually saw that we actually had to take off part of psoas fascia because it really did start to invade into the psoas. This was almost sort of like an XGP sort of like thing right into there. You can see it starting to invade into psoas there. So we took it out, and this just kind of shows you that even with a ureteral access sheath, and we used a pressure bag up around, usually we go to about 200 millimeters of mercury, that there was, still extravasation, maybe some bleeding. I mean, certainly there was no bleeding during the case that we could see, but he did have a cyst on his in his kidney before. And we think that a lot of the fluid went out that cyst and then out around the kidney into Gerota's. The good news was that the renal mass, having the renal mass made it easier to take the kidney out. Well, sorry, you have this complication, but your kidney needs to come out anyways. Let's take it out now. It turned out to be an oncocytoma. Anyways, he's been back to work. I've been in touch with him. He's doing great now. And it was actually very thankful for all the care that he got. So comments, and Roman, great job. So I think we should take any questions, both about clinical things about intrarenal pressure, or love to hear your ideas about studying intrarenal pressure in a lab setting. And I'd like to point out and thank Dr. Naeem Bojani for joining our rounds today too. He's from University of Montreal at CHUM and did a lot of this work. So thanks for joining, Naeem.